Thank you, everybody. I will try and speak slowly so that the translator can keep up, because I tend to speak a little fast naturally. Thank you so much for inviting me to come here. It is a great honour and privilege to be here to share what's happening in Australia and a little bit about IFHIMA. It did take me 31 hours to fly here from my home, so hopefully I won't fall asleep here. And it's great because we're on our way to Germany for the WHO Family of International Classifications annual conference next year, so it made it a good opportunity. For you to understand a little bit about why it's complicated for us to implement ICD-11, you have to understand how very complicated our health system is in Australia. The Australian healthcare system is managed by different governments at different levels who each look after different aspects of health service delivery. For example, our state and territory governments look after public hospitals, but our national federal government looks after the funding of primary care. So it is a very complex arrangement. And then we have private sector, for-profit and not-for-profit, and so on. Many complex interactions between different aspects of the healthcare system that make any kind of change very difficult. Where I work at the Australian Institute of Health and Welfare, we are a national government agency, but we don't work for the health minister. We are a statutory authority, which means we have a separate board. So it gives us independence to produce lots of reliable, accessible information that others can then translate into policy and to support better decision making for health and welfare for all Australians. We do that by trying to tell stories with the data that is being captured, mostly through administrative data sets in the health and welfare sectors. So our vision is to have stronger evidence, better decisions, and improved health and well-being for all Australians. And to do that, we create authoritative, accessible information that, as the image shows there, tries to describe the different health and welfare aspects of a whole person. So we don't think of them in isolation as a patient of health or a student in education or somebody in the legal system or somebody accessing public housing. We try and create the evidence that shows individual journeys through our system. We have a lot of partnerships to do our work. We rely on external committees to advise what we do. We have international partners, and as such, WHO and the OECD are two of our strong partners. Within Australia, we partner with other government departments. Our Australian Bureau of Statistics, who is responsible for mortality data, and universities and all kinds of non-government organisations also. Our collaboration with WHO has been a long one. We have been a WHO collaborating centre for the Family of International Classifications, so the HUFIC network. And we do that in partnership with some of our other government departments. And my team within AIHW is leading our plans for ICD-11 implementation for Australia. You may not know, but Australia has our own clinical modification, like the US and Canada and a number of other countries, called the ICD-10 AM, Australian modification. We use that for admitted patient care coding, which also is used for activity-based funding, case mix funding. It's used in emergency departments as a short list of ICD 10AM codes, and ICD 10 is used for morbidity at the national level. So our journey so far, as with the rest of the world, we have eagerly been awaiting ICD 11, and as the Australian Collaborating Centre have participated in a number of activities in its development, probably the country with the most number of people per capita relative to our population who have been involved in the development. We have participated in many of the field trials that have happened for ICD-11 and also the ICHE, the International Classification of Health Interventions. We also commissioned a report to try and understand what implementation in Australia would be like. And that report recommended that we establish a task force. So last year, the Australian ICD-11 task force was established, and I'll tell you a little bit more about the role of that task force. And just to note that we do have some outcomes in recent weeks where we have provided the roadmap that that task force has developed to our national health committees. So the task force has been operating because it was a recommendation from the stakeholder consultation report, and it was established in 2021 and held its first meeting in 2022. The objective was to build a roadmap of activities that we would need to do in order to make a decision about ICD-11. So it's not a roadmap for implementation, it's a roadmap towards a decision, because there is a lot of information we don't yet know that we need to understand. And it has membership of all of the Australian Government Departments of Health and other relevant agencies. So this is a high-level picture. You'll like my electric vehicle in the middle because we're environmentally friendly. We are in the point now of having developed the roadmap, trying to commence some of the activities that we identified, and I'll talk a little bit about some of those. You'll note there, though, that we are planning to make a decision about ICD-11, hopefully maybe the end of 2025 or early 26. But potential implementation, particularly for admitted patient care, is not likely to happen until about 2031. So there are a number of key activities that we have mapped out across these next 2 years that we will need to do to understand the costs and the benefits for implementation for Australia, given our health system is heavily reliant on it for funding of hospital services. So as I said, our achievements to date, we have developed that roadmap, which is still at a high level, and we have mapped out a number of use cases. So as you probably know, ICD-11 is useful for not only admitted patient care, it can be used in a number of contexts. So we've started to map out what it would look like or what we would need to know to make a decision for admitted patient care versus emergency departments versus non-admitted care, potentially primary care or aged care. We've had very good engagement nationally. We've also developed a vision statement so that we can all, our phrase would be to sing from the same hymn sheet. I don't know how that translates. But, and then we've developed some templates for us to track all of those activities in a consistent way. So at the end of the roadmap activities, we will have some consistent documentation that we can draw together to put it together a business case to take to government. We have in progress still a number of activities. There is a large mapping project happening at the moment, mapping ICD-10AM to ICD-11, And that is really important for us to understand or have that mapping. And what it was also identifying is where there are things we had in ICD 10AM that may not exist in ICD 11. And it provides us the opportunity to try and have those things added to ICD 11. We've also developed a 6-monthly stakeholder newsletter that's trying to keep our broader stakeholder groups like the clinical coders and the educators, software vendors, all kinds of stakeholders up to date with what the thinking is, because there is a lot of fear in the community around what ICD 11 means. Many clinical coders say to me, I'm going to retire when ICD 11 comes because I don't want to have to learn something new. I can see some of you laughing, it might be said here too. So we are planning an engagement strategy, an education strategy. We are talking about how we would gather together ideas for proposals to ICD 11 at a national level rather than it just being piecemeal. And we are doing a lot of international engagement, which is why I'm here today and listening very hard to what you're thinking, because we're all in this together. So we've just been trying to understand what the benefits and opportunities are for Australia. There's certainly a lot for us in a number of really important public health areas where we know that 10AM and 10 don't serve us very well. Certainly in mortality data, things like suicide prevention and sports injury data from the emergency departments are areas that we can see great benefits. We can see the benefit with ICD 10AM being a digital tool to implement more automation of clinical coding. And coders say to me, does that mean I won't have a job? I say, no, you'll just have a more important job. Your job will be more about validation of those results, more than just the abstraction and coding. We're also looking to see how we can integrate ICD 11 with other electronic medical record tools. Could we use natural language processing, machine learning, AI to abstract and code the information from our EMR systems? And we are hoping to undertake some pilots in that kind of field. Again, we could reduce the costs because the development of a national modification costs a lot of money. And then also we obviously want to be able to compare our morbidity data internationally, which we can't do at the moment. But there are a lot of challenges on the road, and I'm sure we're all facing many of these. In our country, digital adaptation, i.e. the adoption of electronic medical records, is not consistent. We are very dependent on ICT vendors, many of whom are big American companies. We don't know how suitable it will be in a variety of different contexts. We have a large adoption of SNOMED CT AU, the Australian version, in Australia in a lot of our systems, and so understanding mappings from terminologies to the classification will be important. And we have not at all had any funding allocated to a move in this direction. Hopefully that was a nice overview of what's happening in Australia. I didn't prepare any slides on IFHIMA, but I will speak briefly about that. As announced at the beginning, I am the president of the International Federation of Health Information Management Associations, or IFHIMA, much easier to say. We are a global organisation that is an NGO in official relations with the WHO, which we have been doing for well over 30 years. We have 22 member countries and 1 regional island network as our members globally, and we represent those national associations and other individuals to try and ensure that health data is being used in the best way possible globally. We are I'm very delighted. We'll be hosting, I'll be hosting the next IFHIMA Congress at the end of October in Brisbane, Australia. So if you haven't organised to come yet, please come. It's a very nice place to come. But we have a session tomorrow. I don't know who's coming, but we have a session at the Ministry of Health tomorrow to talk more about IFHIMA and our potential opportunities to work with those of you who are interested in perhaps joining IFHIMA. I'll leave it at that. Thank you very much.